Greetings. My name is Franck Rahaghi. I am a pulmonary physician, the chairman of the Pulmonary Critical Care Department at Cleveland Clinic in Weston, Florida, and the director of the Pulmonary Hypertension Clinic. And today we have the pleasure of talking to you about dosing and adverse effect management as a team.
Hi, I am Starlet Harrimon. I am an RN. I serve as the Advanced Lung Disease Coordinator at Cleveland Clinic, Florida. And today we're going to be talking about my role in starting patients on Orenitram therapy.
So we got involved in the Freedom trials early on, and including the registration trials. And from there, since then we've learned that we can start the patient at lower doses, maybe titrate them up slower, and go to TID dosing instead of BID dosing for better adverse effect management. And with Freedom EV, we learned that there's really great efficacy on top of another drug, and that patients could probably benefit from it in earlier parts of their disease. And I think that has helped us in patient selection. And I think if you actually start at 0.125 and go up every week, you will get to 3 milligram TID in 6 months. And remember, we're starting this drug in patients that can wait. Yeah, actually, this is a phenomenon across the treprostinil platform, but we also noticed in Freedom EV and even earlier that our patients that achieve higher doses seem to have better outcomes. And Freedom EV actually did show that patients who get to 3 milligram TID or greater have a walk improvement of 25 meters, which actually is a clinically impactful change.
For any type of prostacyclin therapy, we specifically look at the patient's ability to manage the medication. With Orenitram, it's important with titration and their ability to manage that. So sometimes the dosing that we pick for the patient will be based on that after Dr. Rahaghi and I have a discussion. I definitely think that managing their expectations is the biggest part of my job up front. These expectations include how long it's going to take to actually get started on the medication, what their insurance is going to cover. I always try to make them understand that this is a journey. This is not a sprint. We're not getting somewhere super fast. And I want them to understand how they're going to feel along the way before they actually do start to feel better, so that we're able to keep them on therapy. We have lots of posters up in the room that explain what the medication is replacing that their body's missing. And because of that, the side effects that we expect to come with it and how it's going to make them feel.
They need to understand the seriousness of their condition so that they could face some of the challenges of basically titration and managing the early adverse effects of medication. And so we start having a conversation right away about starting the medications and the adverse effects. The way we try to address adverse effects is by addressing it head on as basically one of the biggest responsibilities of our group. And by group, I mean the team of caregivers, which includes the physician, primary caregivers, nurse coordinators, and the pharma industry, and our friends at the specialty pharmacy. And I think one of the most important things we do is right off the bat, we tend to emphasize the top 3 adverse effects that are most likely to occur, which in the case of Orenitram would be diarrhea, headache, and nausea. And we try at the visit to prepare them for the fact that these things may happen and are likely to happen, in fact, and they will leave with a prescription in their hand that would help them manage these top 3 adverse effects. One of the good news is, and you asked about this, is that it does get better over time. And some real world experience with Orenitram as part of the Adapt registry, and it, I believe, followed 94 patients up to 78 weeks, recently showed that common adverse events become less bothersome over time. And in many of these patients, after 6 months, only 6% discontinued due to adverse events.
We by far use TID dosing. This works a little differently than it does with most medications. We're not taking it just at breakfast, lunch, and dinner. It's actually an every 8-hour schedule. Getting used to that schedule can be a big adjustment for people. So lifestyle change is very important for them to understand, to focus, to keep them adherent to the medication. So I normally come in and speak to them after Dr. Rahaghi has. So I do a lot of reinforcement of what he just talked about. We talk about what the expected side effects are. Again, how do we manage them? We'll talk about some non-pharmaceutical ways to manage the side effects, as far as changing their diet, adding peppermint, adding ginger. We talk about when the side effects are going to happen. A lot of times they are when the dose is increasing. So we let them know there's things that we can do if they're having trouble. And I want to make sure that we have open line of communication so they reach out and they know that we're there to help.
Well, obviously, we have a really good relationship with our specialty pharmacy providers. And, it does take a little bit of personal interaction with them for them to know what your needs are and how you manage your patients, and to sort of allow communication to occur freely. Also, when it comes to adverse effect management, at the end of the Orenitram enrollment form, there's an area that says optional and basically allows you to share with the specialty pharmacy some of the strategies that you agree to in terms of adverse effect management, that then they can help you institute that with the patients. So as we mentioned earlier, this is all sort of built upon a direct relationship with the patient and clear communication.
Orenitram, treprostinil, extended release tablets. Indication: Orenitram is a prostacyclin mimetic indicated for treatment of pulmonary arterial hypertension, PAH, WHO Group 1, to delay disease progression and to improve exercise capacity. The studies that established effectiveness included predominantly patients with WHO functional class 2 through 3 symptoms and etiologies of idiopathic or heritable PAH, 66%, or PAH associated with connective tissue disease, 26%. Important safety information for Orenitram. Contraindications: avoid use of Orenitram in patients with severe hepatic impairment, child Pugh Class C, due to increases in systemic exposure. Warnings and precautions: abrupt discontinuation or sudden large reductions in dosage of Orenitram may result in worsening of PAH symptoms. The Orenitram tablet shell does not dissolve. In patients with diverticulosis, Orenitram tablets can lodge in a diverticulum. Adverse reactions: in the 12-week placebo-controlled monotherapy study and an event-driven placebo-controlled combination therapy study, adverse reactions that occurred at rates at least 5% higher on Orenitram than on placebo included headache, diarrhea, nausea, vomiting, flushing, pain in jaw, pain in extremity, hypokalemia, abdominal discomfort, and upper abdominal pain. Drug interactions: co-administration of Orenitram and the CYP2C8 enzyme inhibitor gemfibrozil increases exposure to treprostinil. Therefore, Orenitram dosage reduction may be necessary in these patients. Specific populations: animal reproductive studies with Orenitram have shown an adverse effect on the fetus. There are no adequate and well-controlled studies with Orenitram in pregnant women. It is not known whether treprostinil is excreted in human milk, or if it affects the breastfed infant or milk production. Safety and effectiveness of Orenitram in pediatric patients have not been established. Use of Orenitram in patients aged 65 years and over demonstrated slightly higher absolute and relative adverse event rates compared to younger patients. Caution should be used when selecting a dose for geriatric patients. There is a marked increase in the systemic exposure to treprostinil in hepatically impaired patients. Please see full prescribing information and patient information at www.orenitram.com or call 1-877-UNITHER, 1-877-864-8437.